Thank you very much, Bob and Jim. These debates are always fun. So I've asked to basically talk about skeletal health and IBD, and I'll be taking the position of screening then treating. In other words, follow the guidelines, or rather the recommendations. They're probably not true guidelines. Here are my disclosures, and I do have to say with gratitude to Helen Papa, Francisco Sylvester, and a number of wonderful experts who developed a skeletal health working guideline or clinical report that has very nice recommendations that I'll be highlighting in this talk. I think you all know that osteoporosis is a problem and that you typically hit your maximal bone density and bone mass around in your mid-20s, and then there's a gradual decline over time with a rapid loss and then a less rapid loss. I think you know that osteoporosis is a problem. Another way of looking at the same data is that there's an open window when you actually accumulate bone mass in your teens and 20s. Then that window basically closes where you can no longer accumulate bone mass, so you pretty much hit your peak in your 30s. And then over time, no matter what, you lose bone mass. So skeletal health is important in everyone, but it's particularly important in IBD. Now, what causes skeletal health problems? Well, they discovered a rare skeleton in the deserts of Cincinnati called Denso sapiens here, and they were able to do a number of studies on it. And believe it or not, genetics is probably the most important factor that affects your bone density, but there are other factors that are very important, including inflammation, malnutrition, inadequate nutrient intake, delayed puberty, delayed growth, low muscle mass, and then perhaps steroids and vitamin D play an effect, but these other factors are probably more important, once again, particularly genetics, and we'll get back to that. So, how should you approach the issue of low bone mineral density in pediatric IBD? You can ignore it, that's fine, but you may get into trouble. You can treat everybody, and I think Dr. Denson will be arguing that side, or you can do what I'm going to recommend, which is screen and treat those who need to be treated. So, which recommendations should you follow? These, screen and treat, in this particular paper, Skeletal Health of Children and Adolescents with Inflammatory Bowel Disease. So, what does this paper say? And I'll summarize. You don't need to get DEXA scans on everybody. You want to identify high-risk groups to get DEXA scans on. What are the high-risk groups? Growth failure, such as height Z-score less than 2 or BMI less than 2. This suggests probably inflammation, malnutrition, being underweight. This puts you at risk. Patients with primary or secondary amenorrhea, again, risk factors for inflammation. Severe inflammatory disease, more than 6 months of steroid therapy, or, of course, clinically significant fractures. These are what's recommended to get them on. What kind of DEXA should you get? Well, in children under 14 years, you get a total body and spine DEXA. These are ASBMR recommendations. Children 14 and over, hip and spine is usually what you get. If you look at this particular website, healthcarebluebook.com, it's not a terribly expensive test, with many places offering it for $150 or less. Now, one other digression here, unrelated to DEXA. Who and when should you get a 25 hydroxy vitamin D level on? Now, this is a little bit biased by northern areas that have done most of the research, but I generally recommend getting it on everyone. African American children seem to be at higher risk based on a recent paper by Suber's group. Once a year in the winter, it costs about $30, and if it's low, you can treat this 50,000 units once a week for 10 weeks. So, why screen and treat rather than do nothing or treat everybody? The first thing I want to emphasize is not everyone needs to be treated. There's a bell-shaped curve here. You only want to treat those that are less than 1 standard deviation or below. This whole group here, you don't have to treat. Anyone with a Z-score of more than -1, you don't necessarily have to treat. So even with IBD, 60 to 70% of children with IBD will have a normal bone mineral Z-score. However, if you find a low bone mineral density, you need to follow these patients because such a low bone mineral density may change your therapeutic decisions. How? Well, it gives additional data in patient decision making in terms of explaining risks and benefits. It might, if you've got profound osteopenia, promote you to use medications like infliximab earlier. It may cause you to implement nutritional therapy faster. One would probably consider a more rigorous diet or exercise program. And in patients who are particularly osteopenic or have lots of active IBD, you should consider referring to an endocrinologist. Here's the other reason why screen and treat and why not treat everybody. Adherence, adherence, adherence. And some beautiful work coming from Neil Aliko in the IBD journal that was recently published. And what he showed is approximately 70% of medication doses, not 100%, 70% are taken by children. Approximately 25% of adolescents take 80% of their ASA doses, and approximately 15% of adolescents take over 80% of their prescribed thiopurine doses. So you sometimes have kids that are taking 8 to 10 pills a day, and keep in mind, calcium and vitamin D, 2 to 3 extra tablets per day at a cost of at least $40. Actually, this shouldn't be per year, this should be per month in patients who don't take their pills anyway. So, in summary, I advocate screening and treating rather than treating everybody or treating nobody. Why? Because the prevention of osteoporosis is important. Not everyone needs to be screened. Not everyone needs a DEXA as per a guideline, and you can focus on the high-risk groups. And not everyone needs to be treated. You really want to focus on treating those with a bone mineral density Z-score of less than 1. But if you identify that, I think it's important to treat suboptimal bone mineral density like an extraintestinal manifestation of inflammatory bowel disease. What does that mean? Control your inflammation, optimize nutrition, including vitamin D and calcium, optimize exercise, and you also want to follow up these patients, and as I emphasized, monitor adherence. Thank you very much.